We made it. It's all good.
We did it.
We did it.
So let me just kind of go over like how we work really quick. About you first.
Record. Okay, we're recording on Zoom. We are recording on audio, and I'll count Len down, and then we'll be live. And Michelle, we're taping this, so anything you want to take over, we can edit out or whatever.
Okay.
All right. So 1 second. I have to clear my throat. All right. Len, 3, 2, 1.
Ladies and gentlemen, boys and girls, as always, welcome to Everything is Personal with my wonderful co-host, Mr. John Small. Oh,
thank you.
Get an applause. An applause
Yeah.
today. It's wonderful. Love the
Thank you.
applause.
Thank you very much. It's absolutely a pleasure to be here and very excited about our guest today.
Likewise. Yeah. I think we should just jump into introducing our guest, since our guest has been patiently waiting for so long. I want to introduce, I'm very excited, by the way, because I'll tell you, let me say, I want to introduce Dr. Michelle Weiner, and I can give a whole overview, the board certified and pain management and all that stuff. But I'll tell you one thing from personal experience. There is a lot of cannabis and endocannabinoid system doctors that I meet everywhere throughout the world in my travels, and they really know very little. They just, prescribe or recommend or suggest cannabis. They don't really understand how cannabis works within the body. And first of all, Michelle's a badass. We've been on the panels, and we've talked at different events, and we've had business interaction before. So I can, from a personal standpoint, I can assure you that Michelle really knows what she's talking about when it comes to the endocannabinoid system. So without further ado, there's Dr. Michelle Weiner. Welcome.
Thank you. Thank you so much for having me. I appreciate it.
So can you do a much better job than me telling people a little bit about yourself and your background?
Sure. So I am originally from New York, and I was always very athletic. Yeah.
East Coast.
I was always very athletic, very into nutrition. And, I decided to become a physician. I went to University of Florida, so I'm a Gator. And then that's kind of when I became a Floridian, and, very into health and wellness always. And I decided to study physical medicine and rehabilitation, which really takes a look at the whole body. I'm a DO, so I'm more holistic. I have my master's in public health, and I'm very interested in research and evidence-based science. And then I decided to do a pain fellowship because I wanted to be a little bit more interventional and really kind of look at the whole person. And I realized, how many people are in pain. My grandma suffered from chronic pain, and that kind of really woke me up to how is medicine treating people in chronic pain. And I realized that I learned all these interventions, but, they were kind of Band-Aids, or they were, for acute pain and not really for chronic pain. And I'm in South Florida. I have all these patients on chronic opioids. And that's just not how we're supposed to be treating patients in pain. And nobody was really addressing the emotional, or what I call biopsychosocial component of pain. And people are suffering, and there's, an emotional attachment or trauma or quality of life issues attached to that. So cannabis became legal 4.5 years ago in 2016. I was one of the first recommending physicians because, I just knew that there had to be something to this. There has to be a reason why people were using it in other states. And I wanted to stop just doing what I learned as, a textbook or whatever was FDA approved, and really have relationships with my patients. That's kind of why I decided to be a doctor. And so I started integrating CBD and cannabis into the practice. And then I started doing my own research. Over 40% of our patients weaned off of opioids, and another 40% decreased it significantly. And I realized that it's much more than, one medication for one specific receptor. There's so many components to pain, and people just really, doctors are frustrated. We don't have that many tools, and the tools that we have, it has to be covered by insurance, and then there's a stigma behind it. And so I just started learning as much as I could. And based on the thousands of patients I have, it's very difficult to, say anything back to me, because I realize how satisfied my patients are. I realize how satisfying my job is now. I was kind of frustrated where I was before. And so I've treated patients, not just for pain, but Parkinson's, cancer, epilepsy, a little bit of everything. And I really just was curious. And I think that curiosity is an important component. Being a physician, we have to challenge what we've learned, and we have to also evolve with the times. And if we see that, all these people are on antidepressants and they're not working, or all these people are on opioids, they still have 10 out of 10 pain, why am I going to give you the same medication? So I learned about the endocannabinoid system. I trained a lot of the physicians in Florida. I'm a huge advocate, and I really kind of encourage the patient to, like we talk about, personalized medicine, to take inventory of themselves, to get to know their body a little bit better, and to not just rely on the physician. And so that's really my practice now. It's much more personalized medicine, and really integrating all different natural alternatives into everybody's daily life, promoting nutrition, lifestyle changes, not just using the cannabis plant, but there's much more to optimizing our endocannabinoid system. So that's really how I've evolved, and now I'm very interested in a lot of cannabis research. I have a good affiliation with University of Miami. We just got $75,000 from the state to research seniors who are taking cannabis. So a lot of exciting stuff is going on. We're trying to get Florida to we already have like 470,000 patients actually. So things are moving around nicely here. So we're very happy with our program here.
Yeah, that's one. I think one of the keys that you said, is this me that's giving feedback?
I think it's coming from Michelle's computer.
Okay,
Michelle, do you mind muting when we talk? I don't know why that's happening, but thank you.
I'll try it again. I was just saying that what you said and all that I found like super, super important is the whole thing of being curious. And I don't think enough people, healthcare professionals in general, whatever they were taught, I'm not a doctor, I'm not a healthcare professional, but I've dealt with enough people around the world where they had the blinders on. So this is what they learn in school, and this is what they think is the best way to approach a condition. And everything else, the first thing they say is, show me the double-blind studies, show me the clinical trials. And I'm like, well, they don't exist for various reasons. And there are some that do exist. But what do you think about anecdotal research from thousands and thousands of people that is documented? And to be able to, kind of have that curiosity and ask the right questions, I think that is really an anomaly in the medical profession. I'm hoping that more people will start kind of, gravitating towards that and using their curiosity and just asking questions and looking at the data, like yourself and, other healthcare professionals and, companies like our company, Endo, they're collecting and showing people that this is really something that's effective. And I like what you said about the entire endocannabinoid system. We're not talking about just phytocannabinoids. We're talking about vitamins and supplements and nutrients and all these different things, and are meant to empower somebody to take better control and have that relationship with their healthcare professional so they can work on these conditions as preventative measures instead of just pinpointing to it hurts, let me put a Band-Aid on that pain. So just the question, I guess, around that is how did you kind of come up with that approach? And are you also collaborating with other healthcare professionals that are looking at what you're doing and kind of influencing them to do the same?
So I actually read an amazing book called Good Chemistry by Julie Holland. I'm sure you guys have heard of that.
Mm-hmm.
And she really opened me up to consciousness and connection, right? And so cannabis, people say it's a side effect to have the ability to alter your consciousness. And I think that when we use it for medicinal benefits, obviously, like I say to everybody, if you're using cannabis, even if it's recreational, it's probably for a medicinal benefit. And I've always been pretty, understanding of that. But I like the patient to understand why they're using it. And before they choose to use it, to kind of check in with their, like, it's set and setting, that's the most important thing, right? So the point is that what I've realized over time is that some people's nervous system is just kind of heightened, let's say. We call it central sensitization, where you have one trauma or like I just had a patient today, she had mold toxicity, then she had a death in her family, and then, she developed fibromyalgia, chronic migraines, chronic fatigue. So what happens is your body just doesn't really calm down, and you have this excitotoxic state that you're living in, where your tolerance to the alarm going off is pretty low, and those are the patients I kept seeing. I kept seeing the fibromyalgia where nothing works, but that's because we don't understand the mechanism. And so I started doing my own research, and that's kind of how I started incorporating ketamine-assisted psychotherapy into the practice, and cannabis-assisted psychotherapy, because there's a lot of other, there's a lot of relationships with our opioid receptors and our cannabinoid receptors, but also the NMDA receptor, which is where ketamine works. So we have this wind-up phenomenon where things just kind of continue and they're spiraling, and we're trying to stop it, but there's not much we can stop it with. So sometimes having a break in your day where you can really just rest, breath work can do that. Walking in nature is great as well. But sometimes people need that catalyst to kind of open up. Like, I have a therapist I work with, they can use cannabis and the therapy session is going to be completely different, right? Same thing with ketamine assisted psychotherapy. So it's really just kind of, people are stuck right now, and especially with the pandemic, there's a lot of isolation, lack of connection, and it's a time to kind of bridge that filter between your consciousness and your non-ordinary states of consciousness. And cannabis really can help people get there, can just take a break from the constant rumination and depression and the constant anxiety of the future. So it's amazing plant, obviously we know that, but it also affects so many different receptors. So it's getting the physicians educated on stopping thinking in that single receptor model. Like, serotonin's our happy neurotransmitter. There's 16 serotonin receptors. We can do a lot with mapping the brain based on even the feelings that we have, based on substances or certain techniques that allow us to get there.
Sorry, John muted me while you were talking, so because I kept saying, yeah,
and then it would echo.
Yeah, sorry, I'm in complete agreement with what you were saying. The question, and you're right, and I had this conversation with Dr. Miri in Israel. They call him Dedi, for those of you that may have heard of him. He talked about, cannabis. He was talking about apoptosis, specifically for cancer cells, and he was saying that in his lab, in his models, there's 3 receptor bindings. I know we're probably getting geeky and sciencey for our audience. We're like, holy shit, what receptor? What are you talking about? Yeah, but it's like there's 3 receptor bindings that he saw in his lab for apoptosis. So you're absolutely right. There's multiple receptors, not just like, this is where the whole GW Pharma model of let's single a molecule, let's single a receptor. You have this amazing plant. Why not utilize all the different components and look at the different combinations of the two, or of multiple components? Question for you that I had was about stigma. Do you still see within the physician community and the general healthcare practitioner community, is there still like a pretty prevalent stigma associated with cannabis, even though it's legal in most of the country and in the state that you're operating in?
So to answer the stigma question, it's, first of all, it's a cultural thing, I think. Being in South Florida, we have a very diverse population here. In terms of like the way that physicians look at it, of course, they always want the double-blind, placebo-controlled clinical trials. And we all know about being a Schedule I, how difficult that is to do. But I really do believe that physicians see their patients getting better. And even though we are advancing with research, patients will just say, they're hesitant to tell their doctors that they're using cannabis. But when they do, and they give them that information, they say, well, I had a patient today who's been on 3 different sleep meds, and finally the primary sent him to me. I'm like, if there's one thing cannabis can do, it can help you sleep. And if you're worried about the high, you're sleeping, and there's actually so many ways of minimizing the high. And we always talk about the terpenes and how we can, like the Taming THC, Ethan Russo article, of course, using the terpenes and CBD to minimize the amount of THC people need. But I think that I'm not getting as much of an issue with stigma, because I really think that people are realizing that Western medicine doesn't work for chronic conditions, and that people who are on current medications, they don't want to escalate their dose. They actually just want to decrease their pharmaceuticals.
Mm.
So, cannabis being so non-toxic, and being a pain doctor, it doesn't really intimidate me, because considering I am prescribing opioids anyway, I'm trying to really get people off of these medications. So I don't, at this point, I don't have such an issue with stigma. I think that a lot of people are wondering where this is going, and if, Florida becomes an adult use state, what's going to happen there. But we've even started having the conversation about decriminalizing psilocybin in South Florida, because we want to not repeat what happened with cannabis, which is so much. We're still doing a marijuana 101 lecture, and it's 4.5 years into it. And so we're trying to really educate people on the current research that MAPS has, for example, and get it out there now, so that when something does happen, we don't have to start from square one. So stigma, I think that there's certain cultures that are very, to be honest, like the Hispanic population, they're huge in South Florida. The older population has a very bad stigma about cannabis, and the first thing I always say is, you don't have to smoke it, and you don't have to get high. And just to speak in layman terms sometimes helps them feel a little bit better. But a lot of times they're just so helpless that they just want hope, and that's why they're coming to me.
Yeah, I think it's unfortunate that some people use it as like a last resort, where they should be using it as a supplement to supplement their overall health and wellness. But I think that's still left over from many generations prior to Nancy Reagan, even before that, and Richard Nixon, all that stuff. So it'll take a little bit of time to get it past that. All right, so let's get into the fun stuff that I'm really curious.
Are we going to talk about ketamine now? Okay.
Yeah, let's talk about
fun.
ketamine. I went to a ketamine lecture, and this guy, Dr. Jeff, explained it in a way that I've never heard anybody explain. He explained what chandelier cells are in the brain, and I never really understood this whole concept of this, because cells, when they talk, they go through a neurotransmitter, and there's a synapse. And the chandelier cells are able. Michelle's nodding, for those of you to know, because she's like, yeah, you keep talking. That let me correct you. But all right, let me see. Anyway, so
being very
the visual,
polite.
I'll just paint this visual the way I understand it. So these chandelier cells can communicate without the synapse, and when they do, they sort of squeeze the other cells and from being able to form new productive memories. So a lot of people with PTSD have this rotation, and by the way, there are genotypes that are associated with that keep replaying the same movie over and over, and they have stress reactivity genotypes associated with that. So what happens is, and I saw a visual of this in a slide in a little presentation, when ketamine is injected intramuscularly, the chandelier cell opens up like a flower, and it assumes that ketamine, and it releases that hold. So you're able to start making new memories, and people come out of there like, oh my God, I saw this, I saw that. But here's the challenge, I think, with ketamine, with like other substances. If you don't have somebody who's a therapist or somebody who's trained to be able to pick up on that after the fact, you're going to revert back to your same old movie. You have to be able to guide people towards that light. So that's my presentation I got. Michelle, do you have any?
I love it. No, that's great. I mean, well, to be honest, ketamine has so many mechanisms, right? And there's still probably more. So like, for example, it obviously is an NMDA receptor antagonist, right? Which is kind of in that central sensitization model, really having to do with glutamate, our hyper excited neurotransmitter. So that's the main mechanism. But then, it also affects our AMPA receptor, which affects BDNF, and that's our brain-derived neurotrophic factor. So that's how we create neurogenesis. THC, CBD also creates neurogenesis, right? And there's actually an overlap. There's been studies actually showing how ketamine and the endocannabinoid system actually, correlate. And similarly, there's like 5-HT2A is our classic, psychedelic receptor, and there's crosstalk between that and our CB1 receptor. So actually, you can consider cannabis a psychedelic, because the CB1 actually forms this dimer with 5-HT2A. But either way, so ketamine has a lot of different mechanisms, but to put it, the way I put it to people is it's like what you're saying, it's kind of de-patterning, right? And then adapting to a new mindset. So a lot of it is that ego dissolution, getting rid of your personal narrative, kind of being unstuck. And very similar to what you're saying, you have your amygdala and your hippocampus, right? Where you have your fear response and your memories. And so there's all different ways of trying to decrease the connectivity between parts of the brain, like our default mode network. That is a place where we default to. It's where we keep our personal narrative, our story, who we are, right? Like who you think I am is what my default mode kind of presents to you. And most people need to change their default mode because they have very negative self-talk, or they have, fears that come up. And so the most important thing I will say with ketamine is that you have proper preparation and integration. And that's because even though it's like cannabis, it's dose dependent, and there's multiple routes of administration. I like intramuscular, you can do sublingual, IV, but you need to be prepared. And by prepared, I mean, first of all, you have to be in a very safe place. You have to feel confident with your physician or your therapist. And also the setting has to be, one that you're able to open up in, and your mindset. You have to have a specific intention. This isn't just like, let's do psycho-spiritual growth and have a good time. This is, what is the intention? Because I'll treat a fibromyalgia patient, and what comes up during their session is they were raped, and I'm treating them for pain. They never told me about that. And so clearly I need the therapist in the next 48 hours to have a therapy session with them to kind of talk about this. Because a lot of things, like one of the best books is a book called Your Body Keeps the Score. The body keeps the score. So your body keeps the score of what has happened to you over time. If you end up having trauma and you have pain in a certain place, I know it sounds ridiculous, but sometimes it's actually more of an emotional trauma that just kind of gets stuck in the body. And so you need that somatic release. That's why exercise and meditation is amazing. But ketamine really allows you to kind of dampen that default mode and open up to more opportunities, or not to be so stuck in that perspective. And I also love cannabis for that reason, right? So someone can use cannabis, and within 5 minutes, wherever they felt like they were, in a specific position where they were, let's say, stuck, they can just kind of open their mind, be present to that moment, and out of their fears. So a lot of it is getting rid of emotional trauma and different types of suffering. It can help with pain, especially nerve pain. However, the problem is ketamine, we do it once a week for 6 sessions, and we have a therapy session, within 48 hours after, to kind of discuss what comes up, set an intention for the next session. However, after those 6 weeks, the people who don't have therapy are more likely to relapse earlier on. And then a lot of times within 3 months, people start to relapse again. And so, my fear is really creating a ketamine epidemic, right? The fact that people think that they could microdose ketamine the way that people are microdosing psilocybin is a huge issue, especially on the West Coast. People are getting the, oral troches sent to their house, the lozenges sent to the house. And, at home, you can do it with a sitter and, some guidance, but it's not, it's not ideal. But also we have to figure out cost-effective ways of helping people with mental illness, so ketamine is really a great tool. Again, I say it's not a cure, it's like a catalyst to kind of open up to new potential opportunities in their mind, but it's really like recreating the story. And the other thing is that the therapy really is vital to them having longevity, and that's what we want, is durable changes, right? We want to not start microdosing people on ketamine because they felt great as it was a rapid antidepressant, but then 3 months later they feel bad again. And so sometimes you can, repeat like a booster every, 3 or 6 months, so that you have that. But the point is, the skills that you're learning during the sessions are key to having it not revert back to who you were.
Have you tried ketamine yet, Dr. Weiner?
So I actually have. I actually did a very, very low dose. And to be completely honest, it was we wanted to try a group session. So we wanted to see what, and the reason why is because we're looking for affordable ways of helping people, because there are so many people that are suffering. So we did a group session with many people. We had another physician was there who prescribed it, and we had 2 different sitters, and we had a few people who were participating. Actually, we had 2 other physicians there, and actually one of Len May's friends who introduced us was there.
I'm not gonna mention any names, but I know who it is.
My favorite people. And it was I did a very, very low dose. So I did 75 milligrams of a troche or a lozenge. And usually we do like closer to 200 milligrams for a therapeutic session. And I did that because we were in a group session. You know, I wanted to just kind of feel it. And the reason why is because it's one of those drugs that people really say you can't be a physician or a therapist and understand what they're going through until you've actually felt it a little bit. Which you know, it's similar to cannabis. It's not like I need to take a Percocet before I prescribe a Percocet, but going on this journey, you're having this very